So hi everyone, like I said, I'm Vidya from UNU-IIGH, and that is the United Nations University International Institute for Global Health. And I've been the one who's bombarding you with the email, so now you know how I look. Um, so today we are today's webinar. Today's webinar is part of a larger gender and health webinar series that aims to host timely debates on how to do gender in health. And the background of that is the Gender and Health Hub is coordinated by UNU-IIGH and works to bridge the gap between knowledge, policy, and action. Now, before we go into all the fun stuff that we have planned for you today, I'll do some quick housekeeping announcement. Today's webinar will be in a webinar format, and that means one-way audio and video streaming. However, we may open the floor later on to participants, so you will be able to speak once you raise your hand. In the meantime, please post your questions on the Q&A function and of course on the chat to introduce yourself. I would like to reiterate though, for questions, please make sure to post them on Q&A so it's easier for us to compile all the questions. For the agenda, we have a quick presentation and we will move into the panel discussion and then we open the floor to question and answer. Our colleague Radhika and Felicia are on chat, giving you all the good stuff on chat as well. So do look out for their messages. We're going to hear from two fantastic panelists today, moderated by Nazneen Damji from UN Women. Nazneen is the policy advisor for gender equality, HIV, and health at UN Women, with over 20 years of professional experience promoting women's rights and gender equality. She oversees UN Women's policy and programming efforts on gender equality dimensions of HIV and AIDS, as well as women's health, including sexual and reproductive rights. She brings particular expertise on the socioeconomic impacts of HIV and AIDS on households. She holds an MSc in Economics, Gender and Development from the London School of Economics. To start us off today, we have Dr. Lavanya, who will present the guidance note and checklist for tackling a gender-related barrier to equitable COVID-19 vaccine development. And Dr. Lavanya is a postdoctoral fellow at UNU-IIGH who works on gender and health policy and research, including on the COVID-19 pandemic within the Gender and Health Hub. Now, that's enough from me. I am going to head back to the back end and hand over to Dr. Lavanya for her presentation.
So hello everyone, and hope you all are doing well, and thank you once again for joining us today. Before I briefly introduce the guidance note and checklist, I would like to acknowledge the substantial contributions of all our partners in putting this document together. In case you have not seen it yet, my colleagues will be posting the link throughout the webinar. So we all know the deal. The goal is to vaccinate as many people as equitably, as efficiently, and as quick as possible. Amongst many other factors, and of course the broader pursuit of equity, achieving this goal also requires addressing gender-related barriers and ensuring gender equality and equity in the deployment process. This document provides a set of conceptual points and practical actions for countries to consider. The domains for actions aligns with the WHO and UNICEF's National Deployment Vaccination Plan Guidance, the NDVP, which is an integral resource for COVAX-supported countries. So for those who may not be sold on the why gender premise, gender is a known influence on health seeking, access, and delivery within health systems, of course, and neglecting or insufficiently accounting for gender can lead to insufficient vaccination levels that delay or prevent the achievement of population immunity, a protracted pandemic with repeat escalations of preventable morbidity and premature mortality, which then leads to an extended economic crisis and delayed recovery, and the widening of gender inequities and inequalities, or the regressions of progress in this space. Here are some of the broad approaches we suggest in this document. It is important to identify and act upon gender barriers and related power inequalities, such as mobility, travel requirements, personal agency in decision-making, access to resources, and risks of experiencing harassment, stigma, and discrimination, including while at vaccination centers. A range of stakeholders should also be consulted and collaborated with. This includes women's and community organizations and the non-traditional stakeholders or those who may not have worked together before. The plan and implementation should also be flexible enough to be adapted quickly and be able to be responsive to evolving lessons and new evidence during the pandemic. So moving into the specific domains. Some key action points include the need for gender balance and involvement of local gender experts, women-led organizations, and civil society organizations in the planning and decision-making, and all throughout the implementation of the deployment plans. It is also important that sufficient financing must be mobilized to address gender-related barriers at scale so that as many people benefit as possible. It is also crucial to request for and act on the data, including vaccine safety outcomes in clinical trial, real-world surveillance programs, and the extent of coverage and uptake. The use of sex disaggregated data amongst related variables should inform regulatory decision-making, program design, and the monitoring of progress. On the delivery and supply side, it is important to apply a person-centered approach and think about the door-to-door journey and circumstances of different groups of the population. For instance, community and locations close to home are known to be more accessible for women. On-site workplace vaccinations can increase access and leverage the power of peer influence, and vaccination of the elderly and people with disabilities who require support from caregivers will also need to be factored in, such as their time needed for travel and time off. Programs that are heavily based on digital platforms will also need to factor in how accessible these technologies are for different groups of people and offer alternatives to complement their vaccine access. The human resource side must not be forgotten. A large portion of the health workforce are made up of women, and their safety against any form of violence must be ensured. They also need to be adequately remunerated for their time. As data becomes more available, the plans must also include decisions to include pregnant and lactating women more formally in national programs. Early in the rollout, there was little data to support the use of vaccines in pregnant and lactating women. Formal trials were only announced later, and we have now obtained a lot of outcomes data in this group from the early uptakers, the frontliners, through post-market surveillance. Of course, targeted demand creation is important to build trust, address hesitancy, and ultimately lead to higher uptake. It is important to understand the nuances of how information is accessed, who is considered a trusted source in different subgroups of women, men, and gender diverse people. This knowledge can then be used to craft targeted, evidence-based, and culturally sensitive messages that is co-created with stakeholders who have gained the population's trust and using diverse communication channels that are popular with different groups to maximize outreach. So my time is nearly up, but I invite you to refer to the short document in the link shared through the chat so that you can read more about the checklist. Thank you very much.
Great. Thank you so much, Lavanya, for that. In a very short time, you were able to capture the breadth of what we offer up in this guidance note. So thank you so much for that. I'm really happy to be joining today and to be moderating this discussion. As I was introduced, I'm with UN Women, and UN Women is very, very pleased to be partnering with UNU on this, particularly as we are part of the Global Action Plan for Healthy Lives and Wellbeing. And it's been an amazing partnership to develop this tool together. As you know, COVID has shown us, and the outcomes have shown us, that we do really need a gender responsive health ecosystem. And I'm really, really happy to be moderating this discussion with two excellent panelists who I would love to introduce to you now. Dr. Sarojini Nadimpally, she's a public health researcher and social scientist, currently with the Delhi-based nonprofit SAMA Resource Group for Women and Health. She has conducted and published studies on public health, sexual and reproductive health and rights, reproductive and biotechnologies and surrogacy, ethics in clinical trials, access to medicines, vaccines, patient rights, tribal health, as well as conflict and health. Welcome, Dr. Sarojini. Dr. Helia Molina, our next panelist, is a Chilean pediatrician, a master in public health and an expert in early childhood development. She served as Health Minister of Chile during Michelle Bachelet's second government in 2014. Currently, she is a professor at the Faculty of Medical Sciences at University of Santiago, Chile, and leader in public health with extensive research as well, and several publications in the area of public policies, human rights, and social determinants. Welcome, Dr. Helia. So colleagues, we're going to get right into it with some questions for you. And what I'll ask you to do is, for each of you, this first question, take 5 minutes, please, to respond. We've got a tight agenda and lots of things we want to ask you. Dr. Sarojini, for you first, from your experience, what are some of the strategies that have addressed gender-related barriers? It's really important that we are addressing gender-related barriers and inequalities, and we want to see improved vaccine delivery and uptake. So can you share some of your experiences in other health areas that can be applied to the COVID context? Over to you.
Thank you so much. Thanks for inviting me to speak at this panel. And I find it quite interesting and then similar to something which we are also planning in a way, like in the process of developing something on the, a feminist vaccine policy, in fact. From the experiences of what we had with COVID. I'm really looking forward to learning from other co-panelists and also from the participants, from their questions. It's not just, I will know everything about it, but I think that will be quite exciting if we can, have that kind of space later. I just want to, touch upon 4 or 5 things. I will take definitely 5 minutes because the later part may be very short, but here I thought when we are talking about, we are all aware that the barriers and the threats to equitable access, they are diverse and they're complex. And they're all structured by political, economic, institutional, and legal systems within which, health technologies are developed, distributed and utilized. I'm sure all of you are familiar with that. But yes, the pandemic, apart from having the direct health outcomes, we all know it has also had indirect health outcomes for various genders. It has increased in gender-based violence. It has brought to light gender inequalities within the health system. And it has disrupted essential sexual and reproductive health and rights services and the livelihoods, which are well documented, in fact. Impacted also on the health pursuits of different genders due to COVID-19 include loss of livelihoods and financial independence, particularly for women. In low and middle income countries where larger systems, support systems like regular salaries for community-based health workers, their own social protection, maternity benefits, insurance, they fail to reach the most vulnerable, including the community-based health workers. So the pandemic actually has shaken the feeling of security. And many young girls, I'm talking from the Indian perspective context, had to stop their education due to lack of access to digital infrastructure and they were pushed to undergo child early and forced marriages, putting them at greater health risks. That is also something which we have seen. Additionally, coming to the, there is a growing vaccination gap, with more men getting vaccinated over women in our country, and even harsher gap in the vaccination of trans persons, as a report from India has shown. So in both access to vaccines, as well as information about the vaccine, about the dosage, the adverse events, which vaccine they were administered, and how many doses they should take, women are marginalized and they lag behind with that kind of information. At present, I can tell you only 52 countries out of 194 are reporting sex disaggregated data on infections and mortality. The government also needs to be gender responsive and study the current vaccination trends to identify persons who are missing out on the vaccinations and why. I think that is very, very important. And the other 2 points which I have is access to free vaccines. We have universal immunization program. It never charged any money for immunization in the past. So now the private sector has been roped in, and many private hospitals are charging exorbitant prices. Lack of vaccines and at the free, government centers are pushing people to go to the private sector. And we know, like, out-of-pocket expenditure on health is very, very low in India, very, very high in India, and this is actually, increasing that, and it is worsening the situation further. And the other indirect cost, which we need to look into when we talk about gender, even in the, I'll come back to the strategies in a minute, is about which we never look into it, the indirect costs, which is distance from the vaccination center, like, from traveling long distances from their homes, their hamlets, leaving their child at home. It's a very problematic decision which women would often avoid given their role as caregivers. And I think these are all some things which we need to keep in. Unless vaccination is provided at a nearest sub-center or the health and wellness centers which we have in India, or at the primary health center, the accessibility will be highly compromised. So providing ambulances services, particularly even for women living or other, people living in living with disabilities, which is equally important. And then that's something which need to be looked into. A critical lens to, accessibility of vaccines is very important, because we need to register through an app. And does a digital app website allow for access to vaccine when a large percentage of population in our country, they do not have access to the internet? Is it accessible it is accessible only in English language, which many in the country are not literate and not familiar with English. So these are the things which we need to also look into. Are the vaccination centers physically and other information wise accessible? Coming to the point on the, the strategies which you have asked, which worked or which are not, like, I have not come across any specific strategy improving health for various genders. I'm not just talking about women alone here. We often, it synonymizes women means, gender means women in most of the discourses, but that is, we all know, we can't see in binaries men and women only. Gender cannot be seen like that. So we have a national health mission, and we have a reproductive, maternal, neonatal, and adolescent, and which is a limited manner it addresses SRHR. And there is no such gender-centric health policy at a program that we have. We have a vaccine policy now, which has been again, reformulated, and it does not address these wider gaps. And the central government has limited each state to procure directly from the companies, So the procurement is further, it has to be shared 50% with the private sector in that state. So 50% to the central government, 25% for the states, and 25% to the private sector. So it itself is very inequitable, if you come to that. So we all know about the existing vaccine shortages in many states. People are not able to get even single dose. Even if you're going with the ladder of frontline workers, elderly comorbidities, and then 18 to 45, without having vaccines, without having a clear procurement policy, this is a major challenge which needs to be looked into when we develop any, policy. Recently, the Supreme Court of India, very well, a couple of days ago, has given many directions and asked for information from the central government. I'm just sharing a couple of points which are very important, and I will end with that. It pointed out that the policy, it does not identify persons with comorbidities and other diseases, and persons with disabilities and other vulnerable groups. It was noted that the second wave also affected the persons between 18 to 44 year age group severely, and that the situation calls for this age group to be also vaccinated. So the court also added that everyone above the age of 45 years can be vaccinated on site without a previous appointment on COVID, because many people elderly, they may not be able to use that. So the universal immunization program since 1978, which is one of the best UIP in our country, we have seen successful pulse polio programs and many other, immunization, child immunization programs. So what has changed that now? So we need to see in comprehensive way when we are locating even gender. We need to also understand the larger policy where we can, fit in the gender in that. So this is single procurement model will not work. And that is something I thought, we need to bring in when we talk about the gender barriers within the vaccine policies or any other, national level programs. Talking about, which, even if you say women, which women we are talking about. If you say gender, which gender we are talking about. So that is something very important, I think. Thank you.
Great. Thank you so much. That is incredibly rich. And thank you for laying out also for us, again, a reminder of what are some of the key barriers. And some of them are very much related to infrastructure. They're related to access that are oftentimes not even thought of immediately, such as the app, for example, that is only available in English. So thank you for that. And again, the comprehensive response is really critical and how gender fits there. So I'm going to turn now to Dr. Molina, please, to share with us if you have strategies that have worked in previous experiences dealing with health and immunization that can be applied to COVID. Over to you.
Thank you. Good morning, everybody. Well, I'm very happy to be here with you to share the Chilean experience and to know how you are doing your work in your countries. Well, I think that we are learning every day with COVID, and we need to be aware about the need of more research and to understand better the data and analyze the data to be capable to identify and to quantify the gap of inequity in terms of not only in access to vaccine, but also to health services and on how to have the time and to have the facilities to go to vaccines. Women in Chile and everywhere, I think, have been exposed to more work and rest during these periods of pandemic. 75% of the housework and care is carried by women in Chile, according to recent data from ELO. Some facts are children are at home, they are studying at home, they are studying online. That means for women, another job. They have to work face-to-face or online, and many women are resigning the job because they cannot go there. Care for sick and elderly, 70% are overseen by women in Chile. Unemployment in women doubles that in men, and many have due to resign, I said before, from work due to inability to do face-to-face work. Women have also increased their mental health problem. For example, all the symptoms in terms of anguish, anxiety, insomnia, panic attacks, and depressive symptomatology, around 30 until 50% more than ever. Women have also a lot of responsibilities in terms of the the money that they need at home, and they have to work sometimes in informal jobs, in very precarious work. Precarity. Chile has been able to secure enough doses of vaccine because a very good thing that was very early, the government make the business to buy the vaccines. But even this, we have distributed in all the countries, very long. My country is very long and very thin. We have only 20 million inhabitants. We are in a small country, but we are very long. Then we have different geography and different kind of population in different places of the country. Then we have a very good system of primary health care. That's very important to ensure the access of the population in general to vaccines. We have a good infrastructure, and we have several locations for vaccination and post uniformly distributed in the country. Well, in case with rural or dispersed population, we are using mobile centers to really achieve the population that is isolated in some places. The rollout began for vaccination with the health workers, because 70% of the health workers that are in contact direct with the population are women too. Then followed by the high-risk person, the older population, and the person with chronic diseases or other conditions. Then now we are in the process for vaccination for younger people. In order to facilitate that women who could not leave home at work during normal hours because they have to work, vaccination points added, especially in territories with more socioeconomic vulnerability, and a special hour of vaccination were added in the weekends and holidays to be sure that the people can go there. Money subsidies and bonus were provided for the poorest women, since 50% of the households are headed by women in Chile, and many have informal jobs. This is the environment to produce more gap of inequity in terms of access to health services, to vaccines, or to other social services in Chile. However, social aid has not been enough, sufficient, really, or timely. And then women are at home, are at the street, are working in different things, and maybe they don't have enough time to go to vaccination. But the problem is that we don't have, in this moment, the data separated women and men. We have only aggregate data, and that means that we need to be more active to have absolutely clear the data in terms of different things around the pandemic period. That is very, very complex, and as you say, really we need to have an integral vision, an integral approach, an integral analyze the situation. So it's a high probability, I think, that a gap in gender vaccination exists, but I don't have the data now. But this conversation is very important, and give me very good ideas to research and how the universities and we have the responsibility to put our competence to have information as soon as possible in terms to have the public policies that is going to be need to to solve the problems that I'm very clear that we have problems now, but we are going to have very big problems after pandemic period, because we have really a lot of things that are not working in this moment, because all the efforts are focused on in pandemic and COVID. But well, I'm going to say something about that in the other question to use only my 5 minutes. Thank you.
Thank you so much. And thank you again for highlighting some of the strategies that can be applied, that can be used to reach more people at the spaces and places where they are. But of course, not nearly enough. And I think identifying the data gap is critical. Identifying the need for analysis is essential. And a lot of this is exactly how you want to set the foundation for being able to start a deployment plan and a response plan. So on this, I'm going to add my next question to you both. And this is really about, given all we've heard about the barriers, everything that you both have outlined in terms of the experiences, what now can we say about how this is affecting vaccine hesitancy and confidence? Because again, there's information gaps, there's access gaps, there's clearly a challenge then for the individual woman to say yes, or the individual man or the individual transgender person to say, yeah, I'm going to go get a vaccine. So what are some of the successful strategies you think you've seen or you're seeing in terms of being able to address this issue of confidence and hesitancy with the vaccines? So I'm going to start with Sarojini, please. Let's hear from you.
Okay. Yeah, I think it's very important to talk about vaccine hesitancy, which is going to be more profound due to the what I said earlier is the literacy and the digital divide that already exists. But that is not the only issue which was leading to the hesitancy, because we have to understand and understand particularly the context, the cultural context, where the communities are coming from. And one is, there are two things actually for the hesitancy. One is very clearly about the transparency of the clinical trial data and the, how they are addressing the adverse events following immunization. And particularly from the research to the delivery, there it is adverse events, here it is adverse events following immunization. And if that data is not on the public domain, that will definitely result in some kind of questioning, concerns about the efficacy of the vaccine, and then on whom it has been tried. Like, for example, now, even in the delivery thing for AstraZeneca, we have increased the period now from first dose to the second dose after the COVID second wave. We can, first dose and second dose is almost 13 weeks, whereas UK has brought down. We moved from 6 to 8 weeks, 8 to 12 weeks, now, 13 to 16 weeks. So what is the logic? And these will definitely cause, for who are literate, who are informed, I'm talking about one particular category, they will raise questions about, like, the confidence in the vaccine, definitely. Why these changes are happening, on what basis? And then where is the information? Where is the data? Where is, why we are not disclosing all the protocols on the public domain and the information, how we are addressing them? That is one point. And coming back to the another level, there is the hesitancy. Okay, that hesitancy, is, it's very important to understand the regional and cultural values of the particular community, and ensuring it is a mutual process of understanding rather than forcing them, to get the vaccine, by coercion or by not paying their salaries or by not paying their ration or threats or, which are counterproductive. So we need to, if I'm going to a tribal area, I need to also understand the location, the culture, the context. If they have, there is hesitancy in many parts of our country, in the rural and urban. Urban at a different, I explained, but the rural for different reasons, like, And that is something which is very important in the local language, using different, communication methods, including the local, that I will come later, the kind of strategies which we need to adapt, where we can build a trust. And the third is about the myths, the myths about certain myths about vaccination. I don't know about other countries here, such as women should not get vaccinated while menstruating, okay, because their immunity is very low, so they cannot. And the other is the vaccine might lead to infertility, which is very much, coming in many of the other countries also. They were talking about it. These are, I'm naming some, all of these in the absence of a credible, valid, accessible information, it will definitely worsen the vaccine uptake. So this is something we need to address. Yeah.
Great, thank you so much. And clearly the issue of trust, information, and transparency are key here. Dr. Molina, let's hear from you in terms of the vaccine hesitancy and confidence issue. What are some of the strategies we can be applying to address that?
Yeah, well, I absolutely agree with all the arguments and analyzing the thing that Sarojini is good pronunciation. Well, because in Chile is the same. I think that all the planet exists a lot of myths about vaccines, not only with the COVID vaccine, but also with other vaccines to children or everybody. But I think that we have some problems in risk communication, for example. One thing which is important, really important to be vaccinated, which is very complex to understand, that there is different kind of effectiveness in terms of contagious probability, death probability, go to the hospital probability. I think that is very necessary to be very transparent, but also I think that the WHO validation, the vaccine is highly credible around the world. Besides, I insist that the good communication strategy of risks and the effectiveness of the vaccine is important, but you need to give different message to different populations, to different persons, that they have another cosmovision of life, and then it's different. You can, with a general message, you don't go to the target population that you need to sensibilize about vaccines. Then in Chile, we are in a campaign from the university, the experts, the NGOs related with this problem, to put on the table of the government. They need to be more clear. They need to, and on the other hand, we have the fake news in the social networks that are very common, that the vaccine produces many things, many problems. The women, the pregnant women now are going to be vaccinated, and this is really is a lot of negative commentaries about that. But I think that now we are trying to give to the women more to be more awareness about the need to be vaccinated in terms of give facilities. We are as community trying to put in the government the idea to, I don't know how to say in English, to obligate the chiefs and the employers to give the time around half a day to go to vaccine, to go to facilitate the vaccination. And then we need to work by many factors: cultural factors, working factors, government factors, economic factors. But the most important thing I see is social communication. I think that we need to have social communication, focus on women, focus on young people, because young people don't want to be vaccinated. On the other hand, maybe the older people as me, we are all vaccinated with 2 doses, but it's not the same for the other age periods. We are doing in Chile clinical trials for 3 vaccines: Sinovac, Pfizer, and Seneca. And we are. This is important because we have the voices of the researchers that are giving information. And now in Chile, we are in the period very complex because immediately before the pandemic period, we have a social crisis, a very big social crisis. Then the credibility to the government, to the health services, to everybody is very, very low. That is important to speak, not the politician, not the president of the country, the scientific, the people that have credibility. Very few people have credibility. And then this is a moment to put the person that really the people want to hear, not the politicians, and think that, I don't know in your country, but here the politicians are in the last place of the credibility. But this is important to work in this clinical trial, the phase 3 of the validation of the vaccines. And then this is good for credibility. And we have movement against vaccines, but really I think that in this moment are not very important and not very influencers.
Thank you so much. And thank you so much for raising the whole issue around awareness raising for people in their particular context in their communities, that reaching them with the right message. So I think that's critical, and credibility is essential here. When people think about health and what it is that goes, what they're putting into their bodies, they want to feel confident. I'm going to turn to our last question while we have this panel, and then we will open up for Q&A. And that one is really, given what we've seen, the rapid response that's needed around the COVID vaccine, what are the lessons that we can learn from some of the contexts of disaster and emergency preparedness that we can bring into this conversation from a gender lens, of course? So, Sarojini, if I can ask you that, please. Sorry, you're on mute.
Okay. Maybe a couple of things, because I'm sure they were there in your opening presentation. It is quite comprehensive. You have addressed many of the points which we are speaking now. I think a policy framework, which is very, very important to address, and towards what we are talking about, gender equity and gender equal society, but not by others, but you need to bring them on board. They have to be a part of their increasing participation in the entire policy framing to the delivery. That is something very, very crucial, which is missing. It is developed it's like top down kind of thing, but where is a community, where are their perspectives, where are their issues were taken into consideration when we are developing any vaccine policy or any health policy, any policy. They have to be a part of that, not just the civil society who are amplifying, but the actual, like if I'm talking about community health workers, they have a huge union of ASHA workers, and they should be a part of it. What do they want in this entire vaccine policy is very, very important. I think that is something very important. And I think definitely there is also a stigma and discrimination, which is very subtle, but still that is an issue which we need to look into, particularly when we talk about gender identity, sexual orientation, occupation like sex work, and the citizenship status. And then there are these, we need to have the what do you say, like, submit our own Aadhaar, like unique identity kind of thing, which are very problematic, in that way in our country. And definitely we need to be responsive to new evidence. And I think which is very important, evolving situations, how it is coming and what is emerging from that. And gender considerations and then real time, in the real time. And then there should be planning, listening, involving, and having multiple conversations, which is very important. Couple of things I will say is, one, definitely reduce the financial costs, because it was, we are demanding for free and universal vaccination. India is the only country where we are charging, for vaccines in the private sector. So free and universal vaccination should be a priority. And definitely we need to talk about, how health workers need to be given more, incentives and all, engaging more civil society organizations and all women vaccination centers, which we are thinking of how we can, start that and how can we create that. And that will give some privacy, particularly in the rural belts. And mobile vaccination centers, which can, that can encourage women from the hilly and tribal areas, and people living with disability and elderly lactating women can be benefited and utilized to, come to this. And then that might be, another way of increasing, women coming for the taking the vaccine. So that is something we need to do. And lastly, ensuring gender balance and representation from women's groups and marginalized high-risk groups in coordination and decision-making bodies responsible for COVID-19. Somebody talked about vaccine deployment in the chat box. Yeah, in that gender diverse groups at community and national level should be there. I think this is something which I would like to look at.
Great, thank you so much. I think that that's a critical set of points that you've raised. And I think these are the things that need to be thought of as we go forward. Dr. Molina, hear from you a little bit, some of the experiences dealing with, preparedness and emergencies and those contexts. How are they able to be useful for us here as we do the rollout in COVID? Over to you.
Well, I very agree with some of the statement of Sarah Jean in terms of it's very important to have a policy. We have a public policy and a good planning about how we are doing two things, not only for vaccination, but also for all the areas, social, economic, and the epidemiologic approach in the community to cut the line of transmission of the virus. There are a lot of areas. I think that in Chile, the best thing that we have planned is vaccination, because we had a lot of problem in terms of traceability, detection of contact, and isolation of contact in the social support and the social economic support is very it's not enough, it's very inefficient. But in terms of vaccination, I think that we have good planification. But instead that, I think that the planification is okay. We have maybe in terms of the discourse, we have a transversalization of gender approach. We have a Ministry of Gender, Ministry of Women Affairs that is working in trying to put the gender issue everywhere, always. But it's not easy, because it's very difficult in my country, and I think that everywhere, to work really integrated different areas of the development and to put gender in transversal way to work. Then I think that we have in the paper everything is okay, but the reality is different. But really, the Ministry of Health is working in something. The Ministry of Security, the Ministry of the Women, all are working separated. then I think that it's very important. I think that this pandemic, we have a lot of questions and we don't have all the answers. We are learning every day about this, how the social and the economic and the sanitary areas are working. Then I think that we need a lot of things to learn and to systematize experience, lesson learning, to share among the different countries and the different experience to learn more. We are learning. I think that we are in the process. The effects of the pandemic and the measures taken to control it are not gender neutral. I'm sure, and you are sure too. Understanding gender as roles, norms, and stereotypes that society assigns to the masculine or feminine and power relation between them. For example, one of the lessons learned that is important, all the nurseries and the places from the state free in terms of payment are closed from the beginning of the pandemic period. Then one law was produced to implement a prolongation, it's okay? More time for the postnatal permission to stay at home, not go to work, with payment. And that was very important because we had a lot of problem with pregnancy. ¿Cómo se dice lactancia materna? Breastfeeding. We have problem with the newborns in terms of health too. The controls of many chronic diseases, detection of mama cancer or cervicuterine cancer are absolutely lost in terms of all these health services are focused on COVID. Then the women are absolutely indefensa, ¿cómo se dice?
Don't have access.
Vulnerable for sexual and reproductive health and other issues related with sickness. And we are going to have to learn how to reduce the gap that is we are going to have after pandemic to reduce the mortality and the morbidity of women because pandemic period. Then we need to learn how to planning now for the next month, how to do the things, because this is so important and maybe more important than pandemic in terms of health and mobility and quality of life.
Thank you so much. I think those are critical. I don't want to cut you off, but I'm just noticing the time, and I've not been a very good moderator on time.
Thank you.
But thank you so much. Extremely rich points about what kinds of things we need to be really paying attention to, because we need to prepare for what will happen as a result. It's critical. I'm going to take, I know we have very little time, but colleagues, let's take a couple of questions from the audience. I will start with a question that is particularly in relation to data. There's a question we have here is for both of you. Is there any data about women's participation on the expert government panels and committees which make the high-level policy decisions? There was early evidence that showed a lack of women in COVID response committees. So if I could ask, and very briefly, if you can respond, and then I'll take another question. So Sarojini, if you could come in on this question about data on women's participation in some of these decision-making bodies.
Yeah, like if it is only related to the COVID-19 and then COVID-19 related, the policies and then the interventions or the guidance documents which are coming from the government. And of course, there is a big issue with the women's participation, and then we hardly have very few women. In fact, even the recently formed high-level committee of the government, in fact, of the Supreme Court, which we have one woman scientist who is very well known, Dr. Gagandeep. And we often we also wanted to understand. There are many committees. It is very cumbersome actually, and we really wanted to know who are the members of these committees, and we wanted the names should be on the public domain, and the minutes of the meetings of these committees, they should also be on the public domain so that we will know. It is not always criticizing and commenting, but also to give very constructive recommendations. I think that is something which we are demanding for. But yes, the participation is very low, and we need many women in the policy making.
Absolutely. So thank you so much for that. Hilia, we have a question specifically for you. Chile being a socioeconomically diverse country, what efforts are being made to reach the women in remote communities and address the gender data gaps in vaccine hesitancy and accessibility issues? I'll give you 1 minute, if you can, to respond to that question.
Well, in terms of access in different places, geographical places, there are a lot of strategies more focused on to put close to the people the vaccine, close to the people the medical and attention. But I think that we are not doing well in that area in terms of communication, in terms of participation, how they can be part of the process, how to be more empowered in terms of the different activities that must be implemented in a community, not only for vaccine but also for prevention, for self-care, in terms of aware about the risk. We have, I think that we are doing well in terms to the organization for vaccination, but I think that we have some kind of ¿cómo se dice? No. Poca sintonía, lack of synchrony with the real needs of the people. Real needs. The decisions are taken up and they go to down without participation of the people, and sometimes this is very negative for the results. We are trying to be more to work with the community and to increase that participation, but I think that is not sufficient, and we have and the women always are the most participative part of the society, working and talking with the children, with the older people, but I think that this is now is not working, and for me it's very important, and we are going to put more attention in that. That's all.
Thank you so much. That is extremely critical, and I think a really good place for us to continue thinking. I'm going to give you each 1 minute we're almost done. Sorry, no more questions. I just need one key takeaway message from you. One key takeaway message, and we wrap it up. Sarojini.
It's tough actually, but yeah, definitely, there should be, a larger involvement. What I said, from the planning to the distribution to the, from developing to planning to, systematically how to the implementation. I think till there, the responsibility of the government is to include, when we are talking about gender barriers or gender and equity and distribution of vaccines, and women and other gender, like sexual minorities or women, it doesn't mean that women are not homogeneous. We need to bring in, different women from, Adivasi, tribal or Dalit or racial discrimination, And then many categories are there: sex workers and women living with disability, women in prisons. We don't talk about it. And those are all very important to bring on the board, and then talk about how do we come up with a good policy, which is a comprehensive policy, can address all the needs. But what the previous speaker was saying, which is very important, I'm taking 1 minute, we have to also emphasize on the non-COVID health services. It's not just COVID, because we have seen, because of COVID, there were many, many deaths which happened with non-COVID. And in Delhi, what we have seen in April and May, it's not just because of the vaccines, it was lack of oxygen. So we have to talk in a comprehensive way, healthcare technologies, which includes vaccines, which includes medicines, which includes diagnostics, which includes treatment. If you don't have testing, treatment, diagnostics, and the medicines and vaccines, then it is not going to serve any purpose. That comprehensive approach is very important, not see only in vaccination, not to see vaccination in isolation.
Yeah. Thank you. Those are fantastic last takeaway words. Dr. Molina, one key takeaway in 1 quick minute, and we wrap up. Thank you.
Thank you. Well, it's very difficult to give in 1 minute the approach that we want to, or we are thinking that is important. But I think that we have 3 things that are very important to reinforce, to give all the support, because communication for me is one of the key issues in terms of how to address this catastrophe, sanitary catastrophe, social catastrophe, economic catastrophe. Then communication, transparency, and ¿cómo se dice? Accountability. I think that this is very important. On the other hand, as I'm working in the university in this moment, I think that the university, they have to be a big role in terms of research, in terms of put in the public agenda the most important issues as the gender approach, as research to identify the gaps, to identify the lesson learned, and I think that participation of in different ways of the women in different level of the decision makers, I think that is very important. No, I'm sure that this is the COVID is an opportunity for the world to analyze, to identify, to measure the gaps, to measure really which are the mechanisms of society to solve this gap of inequity. I think that we need to see the pandemic period as a learning period, and we need to be very active. And I appreciate a lot this kind of panel where you can discuss very free without any pressure, and to give your opinion and your experience. That I want to say thank you. I think that we are going to be available for work and to follow in this conversation, because I think that is very, very important. Thank you.
Fantastic. Thank you so much. You have both been excellent. Huge thanks. Excellent. We could listen to you all day, to be honest. And thank you very much. We're going to need to wrap up. But please do follow on Twitter. You can see some information on the chat. Thank you to Lavanya for a fantastic presentation. And we have to close the webinar, and huge thanks once again.
Thank you all. Thanks. Lovely meeting you all. And I hope.
Thank you very much. Thank you.